think Ingrid is aging me just slightly there. 17 years of practice, 10 years of education. That's okay, just in case it was telling on my face. It's a great pleasure to be here in Donegal, and it's a great pleasure to be contributing to this debate tonight. Universal health insurance, is it the answer? I want to thank the McGill School for the invitation to contribute to this debate this evening. My invitation arises as a result of my background as an educator and researcher in healthcare. My view in this debate is shaped by my experience as a provider of healthcare. Over the course of my career, I have worked in many healthcare organisations and health systems, both here and overseas. However, I'm also informed by my experience as a primary carer for an ageing parent. My mother served my family and the country well. She worked hard and productively all her life. She made monetary provision for her old age. She now finds herself in the latter stage of life in need of health services. The degree to which she is reliant, she would never have anticipated or indeed wanted. The carer experience has made real the challenge of access and the experience or patient journey in the Irish health system. These were concepts that I was well familiar with through the course of my work in nursing, education and healthcare research. However, the experience of understanding and negotiating the entitlements to medical care, gaining access to services, and generally grappling with the inequity, lack of clarity, sheer complexity of the system of provision has clarified the substantial imperative for reform in the Irish health services. Some of the challenges in Ireland are not unique and are reflected in the political debates within many countries. For example, the United States has embarked on a major healthcare reform agenda, Obamacare. Even the most critical confirm it to be the first substantial effort to grapple with the problem of access to healthcare for all US citizens. Many believed it would never be possible to introduce a socialised model health system given the frontier and capitalist values of the American people. But it has gone ahead and achieved a measurable level of success, although it has a way to go. So is there need for radical reform here in Ireland? Have we not only finished a process of reform? Is this not what we have been doing for the last number of years? The introduction of the HSC, the centralisation of decision-making, streamlining of processes. Was this not the answer? There are many examples of excellence and high-quality care in the Irish system. The process of reform undertaken to date has produced pockets of success in Ireland. It is important to acknowledge this in a time of increasing pressure and financial constraint that is negatively impacting upon the morale of those working within the health services. The challenges to the Irish health system are well documented and reflect international challenges: an ageing population living longer with more healthcare needs, increasing technological advancement, and the expectations of consumers within a modern society. There are, however, unique challenges within the Irish health system, with the result that it is failing to reach the expectation of Irish people and falls short of the desired first world health system envisaged. We have disproportionately spent on the public hospital sector, without achieving the effectiveness anticipated. We continue to have a consultant-led rather than a consultant-delivered service. We have not given the community sector adequate attention. We have created a dependency upon the hospital system. In fact, that dependency could almost be described as codependency. The more we focus on hospitals, the less opportunity for innovation within the community, further disempowering community providers and indeed citizens from self-management. We do not adequately enable community care providers to achieve models of care that promote wellness and enable people with ongoing care requirements to stay at home. We have made insufficient provision for long-term care, and we've created a reliance on residential care, a more costly option for long-term care. We did attend to manpower planning. We carefully predicted and invested in the undergraduate education of health professionals so they may provide health service in the coming decades. But we exhibit a careless disregard for that educational investment. We appear relatively complacent as to the future impact on care that the current migration of nurses, doctors, physiotherapists and others will have. So why have these reforms not worked? This is relatively a small population, 4.5 million people, would not even make up a community care area in some of our neighbouring countries. We are spending as much on health per capita as many European countries. Should we spend more? The weak association between health spending and healthcare outcomes indicates that spending may not be the solution. The Irish health system is already classified as a universal one, funded in the majority by central taxation. Ireland does provide universal access to specialist services. Hospital outpatient visits are free at point of service. The unique element of Irish healthcare is the mix of private and public patients within publicly funded organisations. The structures that have evolved and underpin the two-tier system conspire to favour private patients over public. There has been considerable objection to the propensity of the system to advantage one over another. Two waiting lists are in operation within public hospitals, with the result that private patients can access specialist care, disenfranchising those most in need. Although objectionable, it is of interest that large numbers continue to pay private health insurance so they may access services they have already paid for through central taxation. It is estimated that even now, although the figure is declining, 45% of the Irish adult population have private health insurance. Could be said that the country already operates a social insurance model, given the percentage of the population who deem it necessary to duplicate cover for acute services, due to the fear the public system will not provide a timely or adequate standard of care. That being said, the protection offered by health insurance is limited. Unfairness is not exclusive to public patients, as even citizens with private insurance are at risk of spending several days on an A&E trolley, and in the absence of a medical card are unable to access community care services and expertise. We have learned that the financial structures underpinning our health system lack the sophistication and refinement that is needed to incentivise and promote effectiveness within the service. A complicating factor of our system has been the unique mix of public and private financing, which perpetuates the two-tier system of healthcare in Ireland. Block and fee-for-payment arrangements are a barrier to development. The financial system contributes to the fragmentation and limits the potential for true integration of care. During the presidential debate of 2008, Tom Brokaw asked Barack Obama and John McCain, is healthcare a privilege, a right, or a responsibility? This is a useful question to ask when considering the reform agenda here in Ireland. We certainly believe it to be a responsibility of the people and the government. 70% of all healthcare expenditure comes from general taxation. We certainly appear to believe that healthcare is a right. On the face of it, we have provided for hospital access to all citizens. However, we also appear to interpret it as a privilege, given that some of our citizens will experience unseemly waiting times and inequitable service. The health system of the country reflects the values of the people. The model advocated by many of our European partners is underpinned by concepts of solidarity and social responsibility, and this is the value system that will best serve the Irish people. There are strengths within a universal health insurance system that is properly and universally and uniformly implemented. It enables the provision of a one-tier system of hospital and primary care with access and treatment based on medical need. All citizens are required to pay on income. The system does not discriminate on factors such as age and pre-existing illness. This differentiates social insurance from private insurance. Every person has equal access. Insurance premiums are paid to a healthcare fund. This protects a considerable portion of health funding from the potential instability of central exchequer funding. The government proposal is to achieve a single-tier system via a multi-payer model of universal health insurance within 5 years. The strategic framework for reform of the health service outlines the priorities: improved health, fair and fast access, free GP care, better management of chronic illness, more people cared for in their own homes, improved quality, safety and affordability. No small task, you might say. Many of the key building blocks for the implementation of universal health insurance are timely and will strengthen transparency, accountability and effectiveness within the health service. For example, hospital groupings, a positive step, and they should provide a vehicle to address duplication and create opportune usage of step-down facilities rather than reliance on acute and high-cost teaching hospitals. GP services free at the point of usage for all. In theory, this should incentivise greater care in the community. The introduction of case management, financial transparency, the provision for consultation around the values and the basket of services, the concept of money followed the patient is to be commended. However, there is work to be done. The basket of services is still to be negotiated. The White Paper does suggest, for example, the emergency department will be provided for through central taxation. The argument for separating the ED from other services is not convincing and is suggestive of an incomplete understanding of patient flow. The emergency department has been inappropriately used as a catch-all in many instances to compensate for inadequacies in care provision elsewhere. The ED, although currently inappropriately utilised, will always be an integral point of access to the acute services. The proposal to exclude from the basket has the potential to be a barrier to optimising patient flow and should be further considered. There is a risk of misaligned incentives if emergency care remains outside the basket of services, whereby providers and insurance companies inappropriately divert patients to EDs, thus perpetuating the fragmentation of care. Achieving universal health insurance does present both challenges and risks. There are some critical milestones to be achieved. The Health Information Act, to provide for an individual health system identifier for each system. This will be necessary to enable billing and tracking of financial information. The reform of primary and community care is perhaps the solution to many of the problems within the hospital system and is a priority that perhaps cannot wait 5 years. This reform will require considerable scale in change management if it is to be achieved. Experience from other countries give insight into the sophisticated regulatory and financial processes that will be needed to execute a multiple-payer model of health insurance. Some have suggested that a single-payer model, similar to that of Canada and Japan, might be more prudent. There is potential for underinsurance if the basket of services is not adequate. The value system underpinning the selection will need careful consideration. The gatekeeper model of care can be perceived to limit patient choice. Access to choice will be required in a modern health system, but solutions can be found. This is a substantial change process. This will require a flexible and motivated healthcare workforce, skilled at detecting and refining obstacles to patient flow. Learning from our experiences, substantial transition will require resourcing and planning. Successive governments will need to maintain that commitment. A key aspect of the success of the universal health insurance system will be the development of high-functioning and effective primary care services, capable of diagnostics and enabling care in the community in a way that we have never seen. This is going to challenge the status quo. Community care will potentially be a 24/7, 7-day-a-week service. The possibility for innovation is endless and exciting. Imagine the person with dementia who develops a urine or chest infection. Common occurrence, you might say. The scenario today: ambulance transfer to A&E, days on a trolley, exacerbation of dementia symptoms, risk of cross-infection, protracted length of stay, all culminating in a potential crisis, predicating the need for residential care. It makes a lot more sense if the health system would incentivise providers to find optimal care solutions. In the person with dementia scenario, appropriately and timely assessment, fluid replacement and antibiotics, administered by the right personnel at the right time, the right location, will offset the need for hospital admission and will result in financial and social cost saving. Social health insurance can be a very positive step towards achieving an equitable health service. Social health insurance is the right answer, but work is needed to clarify the underlying values and to garner the support of the general public. A report commissioned by the Adelaide Society cautions social health insurance is not a policy, but a means to an end. It is a mechanism for providing for healthcare that reflects the values of citizens. The report cautions if the values are not carefully considered, then this mechanism can be applied regressively with negative consequences, such as greater burden on the less well-off or higher costs if the payment systems are not adequate. There is a substantial body of work to be accomplished in gaining the confidence of the Irish people. The 5-year timeframe may be ambitious, and incremental improvements should be initiated before such large-scale reform. Extremely careful planning will be needed to ensure that the insurance contribution is adequate to service the fund and to ensure the basket of services being made available is not limited. If people are not confident, the private sector will re-emerge and we will return to a two-tier system. There is undoubtedly a public relations issue in relation to trust in the health service. The inadequacies in the infrastructure and undercapacity in the Irish health system have contributed to diminishing return in operating costs. It is vital that we address the capacity and infrastructure issues within our health service, even if we do not introduce universal health insurance. The financial crisis has caused us to rethink our values around healthcare. The national response to the withdrawal of medical cards from those most in need reaffirms that the Irish people do subscribe to a philosophy of solidarity in medical care. The Irish Health Service has the capacity to provide a first-world service to all citizens. It is a challenge to contemplate a substantial reform process at a time of financial austerity. However, it is clear we have finite resources to spend on health. That spending we do should be as effective as possible. We are not ethically or morally comfortable with the injustice of our current healthcare system. Universal health insurance is the answer, with the caveat that this is not a quick solution. This will require sustained and committed government policy and a cultural shift among providers and citizens of Ireland. Thank you very much.